I will try to be practical and on the basis of the evidence that we have today. These are my disclosures. We are confronted to two main patterns of biliary strictures, the lower part of the common bile duct and the hilar strictures. And these are two completely different problems. Which are the issues? When to drain, first of all, how to drain, endoscopically or percutaneously or under US guidance, and which stent or drainage to use. So concerning the lower part of the common bile duct, here you see a plastic stent and a metal stent. When to drain? First question. After staging, of course, without stents, because stents may render the staging less accurate, and preferable after a multidisciplinary discussion. The patient is here considered operable. When to drain? Let's have a look at the recommendation of the European Society of Gastrointestinal Endoscopy. This is a strong recommendation, but with moderate quality evidence. When there is a severe symptomatic jaundice, for instance, intense pruritus, that you know it's a symptom that it's very nasty. When surgery is delayed, when there is cholangitis, but this is very rare in naive patients, usually cholangitis is secondary to manipulation, and before neoadjuvant chemotherapy in jaundice patients. But the problem is how to define the bilirubin too high. If you look at the literature, there are different thresholds where the bilirubin has been considered too high, for instance, to include in the randomized control trial of the Netherlands. It was more than 15 milligrams, but other studies report 10 milligrams, 12 milligrams, or even less, 5 milligrams. But let's say that today we consider a deep jaundice when the bilirubin is around 15 or more than 15 milligrams per deciliter or 256 micromoles per liter. Is the placement of stents cost-effective in patients that undergo neoadjuvant therapy in pancreatic adenocarcinoma? There is this randomized control trial that looked at as an outcome at the time to stent occlusion and costs. And as you can see here, the numbers are very small, but the difference is quite significant. And the results of the study indicate that a fully covered metal stent should be the best option compared to uncovered metal stent or to plastic metal stent, because it reduces the delay till chemotherapy in a significant way. Now, how to drain, endoscopically or percutaneously? Again, the European Society of GI Endoscopy, the ESGE, in the clinical guideline that was updated last year, in 2018, suggests to start with endoscopy. That's a strong recommendation, but again with a moderate quality evidence. And which stent to use, plastic or metal? We know from the randomized control trial published some years ago in the New England Journal of Medicine that the plastic stent is probably a bad option. If you look at the rate of complications after preoperative biliary drainage or compared to a group undergoing early surgery, there is a significant difference in terms of complications after randomization in favor of early surgery. So probably today, plastic stents are not a good option. Again, let's have a look at the indications of the ESGE. The clinical guideline indicates to use 10 millimeters metal stents, again with strong recommendation but moderate quality evidence. And against, the ESGE recommends against the insertion of uncovered SEMS because of the risk of early dysfunction, especially in unconfirmed etiology, so the diagnosis has not been established. Why we can use metal stents? Because it has been shown in several studies now that metal stents do not impair unblock resection of the pancreatic head, especially if short stent that leave a long tract of the hepatic duct free to perform an easy anastomosis after resection of the head of the pancreas. Now the question is, do we have to use metal stents for preoperative drainage instead of direct surgery? Because apparently plastic stents are not good enough. That's a work in progress. We have a randomized control trial ongoing, and we have enrolled until now 195 patients out of 294 that are required to close the study. Now let's have a look at hilar strictures. Ideally, a hilar stricture, even if very complex like this one, a type 3, should be drained completely to avoid the septic complications, in this case with free plastic stents. It's not always very easy to do. However, when to drain when a hilar stricture is there? Again, after staging, staging should always be done, must be done without stents, and again after multidisciplinary discussion with surgeons, radiologists, and gastroenterologists and oncologists. When? What does the ESG says? ESG suggests against routine preoperative biliary drainage in patients with malignant hilar obstruction, but again, it's a weak recommendation with low quality evidence. Why? Because also in this case, if the surgery can be done quite quickly, there is no need, unless there is one of the following conditions. If a major liver resection is forecast with a future liver remnant less than 30%, in those cases, it's probably better to drain the liver before the liver which remains before surgery. And when there is a need for monolateral portal vein embolization to induce atrophy and compensatory hypertrophy of the liver, of the remaining liver, when there is deep jaundice, but again, the threshold of bilirubin is not known precisely, and when there is an ongoing acute cholangitis, in those cases, this is more frequent than for lower stenosis of the common bile duct. How to drain? Again, the suggestion of the SGE, it depends on the multidisciplinary discussion and the institutional experience. It depends how the local team is able to approach this difficult stricture endoscopically, but very often we need a combined approach endoscopically and percutaneously. This is the situation when the liver remnant is considered to be less than 30%. First step is the biliary drainage. Again, it's best, I think there is no evidence, but I think it's best to avoid septic complications to drain completely the liver. Then, and this may be done also percutaneously, of course. Then the second step will be the portal vein embolization of the liver that will be resected. And after, that's the result of a portal vein embolization. And then after 1 month, after 4 weeks, usually you get a hypertrophied liver remnant, and then you can proceed to a very extensive resection, like in this case, an extended right hepatectomy to segment 4 and to the caudate lobe. Which stent to use in hilar strictures? This is completely different from the lower part of the common bile duct, because in hilar stricture, preoperative drainage should be done with plastic stents or with percutaneous drainage, again with a plastic drain, because if you use metal stents, you will impair surgical resection. And again, I am very favorable to try always to drain completely the liver to avoid septic complications while waiting for surgery. The technique is very important. You must avoid to inject before being sure to be able to drain, and therefore first you pass a guide wire, then you inject once you are in the sector or segment that you want to drain, and then you place the stent. Same for the left lobe or the posterolateral lobe. In this case, this was a Bureau 2 patient, and finally 3 plastic stents were placed. Is there a role for nasobiliary drain? Apparently, at least in this Japanese experience published a few years ago, this was a retrospective evaluation of a big number of cases where they used the unilateral nasobiliary drain of the future remnant liver, of course, and this was effective for a preoperative drain of hilar cholangiocarcinoma. They considered endoscopic sphincterotomy as an adjunct to risk factor for cholangitis, so nasobiliary drain may avoid it. And they suggest to place a nasobiliary drain without sphincterotomy. I think that this will be difficult to do in our setting in Europe. So, in conclusion, the stricter location is what makes things different. When to drain in lower common bile duct strictures, when there is deep jaundice, and when there is delayed intervention programmed. For hilar strictures, again, deep jaundice and major liver resection requested. How to drain for lower part endoscopy, for hilar stricture endoscopy and the combination with percutaneous technique. Which stent? Fully covered or partially covered metal stents for the lower common bile duct, plastic stents or biliary drains for the hilar strictures. So finally, in an ideal world, without preoperative biliary drainage, that's the story of a patient. 8 a.m. he is admitted here for jaundice. Bilirubin is 5 milligrams. At 8:30 he gets ultrasound, dilation, no stones. At 9:30 he gets a CT scan. There is a small pancreatic mass with no vascular invasion. At 11 a.m. He gets a US FNB or FNA, and at the 3 p.m. we have the results from the pathology department, meeting at 4 p.m., and the following day, pancreatic duodenectomy. That's a dream. No need for preoperative biliary drainage, of course. In the real world, with preoperative biliary drainage, there is very often a delayed diagnosis at the community hospital or a general practitioner. There is a difficult staging. Not all the CT scan machines are good enough today. There's no access or difficult access to EOS facilities, and there are delayed therapies because pancreatic surgery is usually done only in referral centers, and the operating rooms are very busy. And this makes worsening of cholestasis and jaundice and will require a preoperative biliary drainage in this case. Thank you very much for your attention.